Hi, everybody. I'm Sujana Chandrasekhar. I'm the past president of the American Otological Society.
And I'm Brad Kessler. I'm the education director for the AOS.
What a great slideshow, Brad, huh? It really
Absolutely.
It just shows what the society is all about: education, research, and camaraderie, and some pretty
Sujana,
good
there was a picture of you in pure joy. Just a beautiful picture.
Thank you. That was from the banquet when I was president, and I was very joyous that day. Yes, indeed. So we are so happy to welcome you to the third American Otological Society webinar. This one is called Sound Mind, Hearing Loss, and Cognitive Health. And on behalf of Dr. Nancy Young, who is the current president of the American Otological Society, and the entire council, we'd like to welcome you here. I just want to let you know who your council members are. From left to right in this picture is Dr. Dennis Poe, who's member at large, myself, Dr. Howard Francis, who's member at large, Dr. Nancy Young, who is president, Dr. Bill Slattery, who is immediate past president, Dr. David Friedland, who is secretary treasurer, Dr. Nick Blevins, who is president-elect, And in that little computer screen at our last meeting is your friend and mine, Dr. Brad Kesser, who is our education coordinator.
Thanks, Sujana. You know, the AOS is proud to develop and present these educational webinars. And we've done one on new technologies in advancing otologic surgery. We've done one on facial nerve monitoring with the late Jack Cartouche of blessed memory. And we did a combined webinar on wellness with the British Otological Society. If you'd like to catch any of these webinars, they are available for viewing on the AOS YouTube channel. So feel free to log in. The QR code is on the screen, and you can view any one of these educational webinars. And tonight's, of course, will also be posted on the AOS webinar. Now, Sujana, not only is tonight an excellent night for education, but there's something else going on. Do you know?
What's that, Brad?
Tonight is the deadline for all abstract submissions to the 159th annual AOS meeting as a part of COSM in Phoenix, Arizona. 11:59 p.m. on Pacific time. So that means the East Coasters have until 3 a.m. to get an abstract in. And we were told today by Kristen, our administrator, there already are over 100 abstracts that have been submitted to the AOS. I mean, that program advisory committee's got its work cut out for them for sure. So tonight, 11:59 p.m. Pacific time, send in your AOS abstract. ANS abstracts are also due at the same time. And that tells me to remind you to please come to the AOS and the ANS meetings as part of COSM. That'll be April 24 and 25 for the AOS meeting and April 25 and 26 for the ANS meeting. I'm sure we'll have excellent panels, discussions, scientific sessions, and outstanding keynote speakers in both society meetings. So the ANS call for panels is due October 22nd. Please come to COSM in Phoenix next April 24 to 26 for the AOS and ANS meetings. Thanks.
Yes, and we're very excited about meeting in person. We're also very excited to continue this this initiative of webinars that we started a little while ago. One of the beauties of the platform that we use, which is powered by a company called Digimentors, is that you can participate live. So Elliot Zakharowitz from Passaic, New Jersey, gets the first prize for logging in and telling us where he's listening from and watching from. Please do let us know where you're watching from, whether you're an otologist, an otolaryngologist, an audiologist, other kind of professional, or just a person who cares about this important subject matter. Brad's job for this webinar is going to be behind the scenes, where he will be collating all of your questions and comments as the talks and the Q&A go on, and he'll be highlighting the ones that we can answer for you. So Brad, thank you so much, and have fun backstage.
My pleasure. Good luck. Thanks, Sujana.
Thank you. So we're going to get the webinar underway. And just continue, please, to let us know where you're from. I see Anna Kim is watching from New York City. She's an otologist. Kristen Bordignon, who's our administrator, is watching from Florida. Deborah Burke is watching from Bordentown, New Jersey, and she's an audiologist in my practice. I'm in part of a huge practice, and she was very kind to email me right after I sent out the notification about how important she felt that this subject was. We have Anlib Khan, who's an otologist in Maryland, Lisa Bell, who is an audiologist and a cochlear implant specialist in New Jersey, Katie Kennedy, otologist in Camden, New Jersey in the house. Justin Golub is watching right before he starts talking, which is super nice of him. So keep letting us know. As we start this webinar, I just want to tell you who our speakers are. So our webinar is entitled Sound Mind, Hearing Loss and Cognitive Health. This was Nancy Young's idea, and I think it's an outstanding and timely idea. Our speakers will be Dr. Justin Golub, who is Associate Professor and Vice Chair for Faculty Development in the Department of Otolaryngology, Head and Neck Surgery at Columbia University Vagelos College of Physicians and Surgeons in New York City. Dr. Richard Gergel, MD, is Professor of Otolaryngology, Head and Neck Surgery at University of Utah Health in Salt Lake City, Utah. And Dr. Carrie Neiman is Associate Professor of Otolaryngology, Head and Neck Surgery at Johns Hopkins University in Baltimore, Maryland. So let's bring on our panelists and say hello. Hi, everybody.
Hi, Sujana. Thank you so much for inviting us to be here tonight.
Yep. Hi, Sujana.
Glad to be here.
I'm so glad that you're here. So their talks, my friends, are super outstanding. I think that they will give us a lot of knowledge and then give us some questions that we can ask and maybe some comments about what's going on in your practice, or as Al Roker might say, in your neck of the woods. So let me just do a quick introduction of the subject. So this subject is important not just to otolaryngologists and otologists and audiologists, but actually all of us as we age, as maybe we take care of aging parents, as maybe we develop some hearing loss, and we want to live the fullest and richest life as we get older. So let me share a couple of slides with you from the World Health Organization. The problem is enormous. So 1.5 billion people in the world are affected by hearing loss, and a significant percentage could benefit from amplification or other means to improve their hearing, and they are not. Hearing loss is on the rise, so that 1.5 billion is from 2019, and you can see that it is shortly going to be over 2 billion and approaching 2.5 billion people who are being affected by hearing loss. We as healthcare providers and even as people, we're all very much more aware of hearing loss in children. So the hearing loss in children is something that we know affects a huge number. It can delay speech and language. It can cause some isolation. It even causes a higher risk of injuries, and very related to how well you can perform in work life, either as a parent or as a child growing up with significant hearing loss. There's unfortunately higher levels of poverty in children who are affected by significant degrees of hearing loss. But in adults, we often don't pay as much attention. So in adults, we all expect some hearing loss as we get older. Everyone sort of expects that, grandma or grandpa is not going to be participating as much in family conversations. But why should they miss out? And why should we miss out on their participation? So we know that untreated hearing loss in adults causes isolation. As we get older and are still in the working world with untreated hearing loss, reduced job performance and earning power, diminished psychosocial and physical health with untreated hearing loss. There's some safety and balance issues. People with even mild hearing loss have a 3 times higher risk of falls than people without hearing loss. Increased rate of hospitalization and even premature deaths, which is, kind of tragic. Cognitive decline, and this is something where we really want to parse this out in this next hour or so. Adults with hearing loss have 30 to 40% faster decline in cognitive abilities than people with normal hearing. And there's a lot of psychological issues, fatigue, embarrassment because they're missing. I had a patient once who heard, and please pardon me, he was at the checkout counter at the grocery store. He heard, "Pay up, you bastard." And of course, this nice girl behind the cashier was actually saying paper or plastic. So, that's embarrassing. And it's hard to kind of get the nerve to go back into such situations. So stress, tension, feeling of being rejected by others is really an important occurrence. So the World Health Organization has really set some targets by 2030 for us to address these. We know that hearing loss costs almost $1 trillion annually, and the return on investment for every dollar invested is about 16 times if we can invest early and treat that hearing loss. So this is the stage for this presentation. I'm just going to say some more people have checked in. Let's see. Mickey Price has checked in. She's an otologist in New York City. Her practice is in Brooklyn. Her life is currently in the Upper West Side. Welcome to Manhattan. The Yukon Otolaryngology Residency, Dr. Parham, so nice to see you here. Dr. Parham is not only an otolaryngologist, but very concerned with geriatric otolaryngology and obviously with training. My parents, Dr. Sridevi and Hosikari Chandrasekhar, are watching. My dad's an otolaryngologist. My mom's a family physician. And we talk about hearing loss quite a bit. Jack Shohet's checking in from Orange County, California. He's an otologist, and he says this is a great format and subject matter. Thank you to the AOS for putting this on. Thank you, Jack, for tuning in. Let us know where you're listening from. While you're trying to figure out where you are, let's have our first speaker. So we're going to have 3 speakers, and then we're going to open up for a lot of Q&A. I'm very excited about the interaction that I'm sure we're going to get. So our first speaker is Dr. Justin Golub, and he's from Columbia University in Upper Manhattan. Justin, take it away.
Thanks, Sujana. Honored to be here and excited to give this talk. And we got my slides up. I'm Justin Golub. I'm an associate professor at Columbia University in New York City. And I'm going to be talking about hearing loss and cognition when the relationship begins. And I've included some background as well. These are my disclosures. So I put a little cheat sheet to make this nice and simple. It is the evening as it is. So anything in red will denote hearing loss, and anything in blue will denote cognition. So hearing loss, very, very prevalent. For example, over 80% of people who are over 80 years old have hearing loss. And at the same time, treatment is actually fairly rare. Under a quarter of people who are over 80 years old actually do anything about it, i.e. wear hearing aids or choose surgical interventions. And that disparity is very noteworthy, particularly because we increasingly think that hearing loss, shown here as the typical audiogram of plain vanilla age-related hearing loss, increasingly we think that hearing loss may affect the brain. It could cause cognitive decline, depression, other issues in later life. And if you look at this axial slice through an MRI, it just sort of makes sense that hearing loss may have an effect on the brain. So shown in the red box, for those who don't already know, this is the inner ear, and in the blue circle is the brain. And the ear has basically one job in life, which is to output to the brain. So it just seems at a very basic level, if something happens to the ear, this might have a consequence on the brain. So this field, I would argue, really exploded about 15 years ago when my mentor and colleague, Frank Lind from Johns Hopkins, published this paper looking at the relationship between hearing loss and dementia. So in this study, he used hearing loss as the exposure. And back then, this was fairly unique. Hearing loss was measured by audiometry. Prior to then, would often be survey-based questionnaires. So high-quality hearing measure. And the outcome was new cases of dementia. And the cohort was the Baltimore longitudinal study of aging. And there were about 600 people. And it went for about 10 years, 12 years. And critically, they adjusted for potential confounders. So a confounder is something that can cause both the exposure as well as the outcome. So age, demographics, cardiovascular risk factors were adjusted for. And this is what they found. So on the y-axis is hazard, which is kind of like risk of dementia. And on the x-axis is hearing loss, going from 0 to 100 dBs of hearing loss. And you can see that as there's more and more hearing loss, the hazard or risk of dementia goes up, 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 to the point where people who have severe or greater hearing loss have 5 or more times the risk or hazard of getting demented. And this was really an explosive finding. And it has since been substantiated in a number of papers, culminating in these Lancet commissions, which will probably come up by some of the other speakers today. The most recent one was in 2024. And these commissions look at major risk factors for dementia. And in 3 out of the 3 of these commissions, hearing loss was cited as the #1 modifiable risk factor for dementia. So how would hearing loss potentially be related to dementia? This is usually the follow-up question. And so there are sort of three key causal pathways that link hearing loss to dementia. The first is change in brain structure. And the way this works is that hearing loss, which is connected to the brain, might cause the temporal lobe to shrink quicker. Newsflash, as we get older, our brain shrinks. And studies have shown that people with hearing loss, their temporal lobes shrink quicker. And the temporal lobe is in turn connected to other structures. And you could see how this could have cascading effects on the brain. And the second pathway is through socialization. So hearing loss will cause people to socialize less because it requires more effort. It leads to awkward encounters, like your cashier being super rude to you. So you may stay at home and withdraw more and not have as many cognitively stimulating conversations later in life. And then the third pathway is the cognitive load pathway. And so what this says is that if you really focus with hearing loss, you can make out the words, but at the expense of processing the actual content, the meaning of what's being said. And so over time, this is probably not good for your cognition. So something that I become interested in is when the relationship actually starts. In other words, at what level of hearing loss does it actually become a problem? And so this all began in my group about 6 years ago with this study where we looked at minimal levels of hearing loss, which I termed subclinical hearing loss. So the exposure was an audiogram, and the outcome was a bunch of cognitive tests. And we used this pre-existing cohort called the Hispanic Community Health Study, which is a national study at 4 sites. And critically, everyone in this study had basically normal hearing, appeared to an average of 25 decibels or less. And it contained about 4,000 people. We looked cross-sectionally, and we adjusted for potential confounders shown here. And what we found is that among these people with subclinical hearing loss, for every 10 decibels worse your hearing got, we found an association with worse cognition in, drumroll, every single test. So I'm not going to go through these numbers and tests, but suffice it to say that all of these cognitive tests had a significant and also clinically meaningful relationship with hearing loss, even among those with minimal levels of hearing loss. So the conclusion is that the hearing cognition relationship may begin earlier than previously recognized. And the current 25 dB definition of hearing loss that's often used for adults may be too high, I would argue. And we should definitely optimize hearing regardless of the hearing level. And then we've since substantiated this in other papers, including longitudinal studies. So we think it's a robust finding. I really like this picture here, which is from the Hearing Number Initiative from the Cochlear Center at Johns Hopkins, which looks at ways we can help with hearing. So in the otolaryngology and audiology world, we basically focus on the bottom 2 items. But if you have lesser levels of hearing loss, there's other technologies and things that can help, from over-the-counter hearing aids to just simple everyday technologies, things like microphones, good acoustics, good lighting. And this matters because people with minimal levels of hearing loss, they need to hear too. And this actually may make a difference. Over-the-counter hearing aids exist now, which is for people who have minimal levels of hearing loss, less than people would typically get prescription hearing aids. And Apple has entered the market. So the AirPods Pro with a push of a button can become an over-the-counter hearing aid. There's more and more data showing that hearing loss can be bad for your mind. This really culminated with the ACHIEVE study a few years ago, which showed that among older people who are at risk for dementia, hearing aids slowed cognitive decline. And here at Columbia, we're doing a randomized control that's similar to ACHIEVE, looking at lesser levels of hearing loss. We're looking at 150 people, same groups as ACHIEVE, and we're looking at cognition, socialization, and fMRI. So in conclusion, hearing loss is common, treatment is rare, hearing aids may reduce cognitive decline among those at risk for dementia. The effects of hearing loss may begin earlier than previously realized, even when you don't technically even have hearing loss yet, which we term subclinical hearing loss. And then finally, I think we need to think beyond hearing aids to earbuds and other technologies as one device and think about acoustics in the environment. Thank you very much.
That was fantastic, Justin. Thank you so much. You know, I was reading after you and I had talked a while ago, the World Health Organization is also looking to make 20 dB the cutoff.
Yes.
So it sounds like that data is really important. And, you know, I'm just feeling, I'm feeling like there's a lot we're learning today. And I know we're going to get a lot of questions in the chat. So I'm going to let you go backstage for a while. I'm going to say that there are more people checking in, so thank you for checking in. Dennis Poe, who is on AOS Council, is checking in from Boston, and he says it's great that we're discussing this important topic. Alex Arts is checking in from Ann Arbor, Michigan. Excellent topic. Thank you, Alex. Cesar Franco Peña is checking in from Paraguay. So, bienvenido, Cesar. And thank you so much for listening and tuning in. And if your friends are not listening or able to watch right now, but they can watch later, please let them know they can watch later. All of this data will be on the AOS YouTube site. Hamed Sajadi is watching. Great program. Thank you, Hamed. I think we are off and running, and I'm very excited to introduce our next speaker. Dr. Carrie Neiman is from the Johns Hopkins University Medical Center, and she has a lot of really good information to share with us. So welcome, Carrie.
Awesome. Thanks, Sujana. Great. So just like Justin, I'll give a little bit more introduction. I'm an associate professor at Johns Hopkins, and I'm core faculty at the Cochlear Center for Hearing and Public Health at the Bloomberg School of Public Health. We're going to continue our focus on hearing loss and dementia, but we're going to specifically look at, for those who are already aging with dementia, what do we know and what does that mean? And a little bit more importantly, what can we do about it? I have no industry-related disclosures for this evening. Justin just walked us through this very beautifully, a little bit of our understanding about hearing loss as a potential risk factor for dementia. What we're talking about here, though, is what we're talking about in terms of dementia and hearing loss coming alongside each other and really at the intersection of two really significant public health challenges. Just like Justin mentioned and called attention to the Lancet Commission on Dementia, their very first report back in 2017 was a real landmark, and they labeled dementia as the greatest global challenge for health and social care in the 21st century. And why is that? That's because dementia is incredibly common. It has very few to limited therapeutics, and it has a great deal of burden and cost both to individuals, families, and society. So if we look in the United States alone, 1 in 9 older Americans have dementia. 1 in 3 older Americans will die with the diagnosis of dementia. And so we're only at the beginning of understanding hearing loss and dementia in terms of when they're coming alongside each other, but we'll start with some basic questions to get us going. So can persons living with dementia complete a hearing evaluation? For many people in the clinical audience here, no, the answer is yes, they definitely can. And that objective assessment is really, really important. Self and proxy reported measures of hearing in general for older adults is really limited, but particularly when we're talking about individuals with cognitive impairment, can be particularly problematic. But pure tone audiometry is certainly possible, it's reliable, and tablet-based options are also possible for this population, so we can really think very broadly about where, when, who we can get information about in terms of at least some basic hearing screening for individuals living with dementia. So how common is hearing loss among persons living with dementia? Well, we have some of the first nationally representative estimates now. Around 79 to 80% of older Americans with cognitive impairment have hearing loss. And we know that age is the biggest risk factor for hearing loss. Age is also the biggest risk factor for dementia. And so what do we see when we look at the oldest old in terms of those who are 85 years and older? We see 94%, almost 95% of older Americans who are 85 and older with cognitive impairment have hearing loss. If we think about those numbers and then we look at other kind of common comorbidities we're often thinking about in terms of dementia, the numbers around hearing loss are much, much higher. So when I think about it and when I talk about hearing loss, particularly when we're talking about people who may be outside of the hearing kind of space, we need to be talking about hearing loss as really one of the most common comorbidities that's coming alongside dementia. So how common is hearing aid use among persons living with dementia? From that same kind of nationally representative estimates, we see around 22% of older Americans with cognitive impairment and hearing loss use hearing aids. So it's a little bit lower than what we see in terms of nationally representative measures around older adults in general, but it's low. It's low overall, just like Justin pointed out. So we've spent a lot of time thinking about hearing loss in the context of healthy aging, but does hearing loss actually matter for persons living with dementia? So when we think about persons living with dementia, there's some things that certainly we come to mind. Something that we'll talk a little bit more about is something called neuropsychiatric symptoms. So is there a role for addressing hearing in terms of reducing neuropsychiatric symptoms? When you think about the potential for reducing falls, strengthening care partnerships, delaying institutionalization, maintaining connectedness, we certainly have a lot of work to do to explore these areas, but we can understand how hearing loss may have a role across a number of these areas that really matter for older adults who are aging with dementia. So let's talk a little bit more about neuropsychiatric symptoms. So neuropsychiatric symptoms are the non-cognitive aspects of dementia. Really, neuropsychiatric symptoms are one of the biggest drivers when it comes to just how burdensome dementia care is, how costly dementia care is, and when we think about risk factors for institutionalization. So neuropsychiatric symptoms are things like irritability, agitation, anxiety, apathy, depression. These are very common and affect almost all individuals with cognitive impairment at some point over their disease course. And when we think about this, right, and we think about somebody with hearing loss who may not be able to hear as well, their care partners, their loved ones may not be able to connect to the environment as well as they should, we can see how that may be a potential driver for things like apathy or depression or agitation. And so we ask the question, is hearing loss associated with neuropsychiatric symptoms? We looked within the memory clinic at Johns Hopkins, where we have audiometric information along with robust information in terms of clinical factors. And what we saw was that for every 10 decibel increase in hearing loss equated to around one additional neuropsychiatric symptom. Hearing aid use seemed to be protected. It was associated with 2 fewer neuropsychiatric symptoms. In terms of severity of neuropsychiatric symptoms, we saw that every 10 decibel increase in hearing loss equated to a 1.3 increase in neuropsychiatric symptom severity. And hearing aid use was associated with a 4-point decrease in neuropsychiatric symptom severity. So I know those points are pretty difficult to conceptualize. What does that mean? Well, when we look at 1-point increase in NPI, which is a common measure of neuropsychiatric symptoms, equated to a 2% increase in daily costs of dementia care. So when we think about hearing aids, right, a non-pharmacological intervention, a low-risk intervention that may have some potential for improving neuropsychiatric symptoms, or at least protecting against it to some degree, there's something to be said there in terms of, trying to move that needle in terms of care burden for individuals, families, and society. So does addressing hearing loss improve neuropsychiatric symptoms among persons living with dementia? Prospectively looking, in terms of just looking in the past at charts, whatnot, do we see that prospectively? So we did a small pilot study a number of years back. This was in partnership with Sarah Mamo when she was on our team at Johns Hopkins, did a 1-hour really targeted intervention using over-the-counter devices, and we could see that improvements in neuropsychiatric symptoms. There's certainly limitations with this pilot study. So we're looking at this now with a larger randomized controlled trial that we're excited to be opening now, and much more to come. So what are things that we can do for persons living with dementia in our clinic? Well, the first is communication strategies. We know these well. We need to practice them. We need to train our care partners in them. We need to be talking about large and simple devices like the good old pocket talker and the super ear. And so we know that hearing loss is highly prevalent among persons living with dementia. We need to be talking about it as one of those common comorbidities that comes alongside dementia. It matters for individuals who are aging with dementia, and that hearing care may be a low-cost, non-pharmacological intervention that we need to be talking about if we truly want all of our older adults to have access to the tools they need to age well. Thanks so much.
Thank you, Carrie. That was fantastic. Couple of just pointers I'll make is, I see families all the time where, there may be a little dementia. There's definitely some hearing loss. The wife is speaking from the kitchen with the dishwasher on. The husband is somewhere else, not paying attention. There's fights. And at some point, the communication stops. And I think even though we all know that very elegant slide of looking at the person, getting their attention, not over-enunciating, but actually talking like a person. These are really important. And I think reiterating those to our patients and their families is so very important. The other thing I'm going to say is that, when people are living in assisted living facilities, I find that the staff members are very uncomfortable with hearing aids, right? And I think we need to my personal belief is we need to figure out a way, just like in schools, we finally got schools and school nurses to be comfortable with hearing aids and FM systems, right? There has to be a way for us to take that beautiful data and translate it to normal activities that will, like you said, get us to be as fabulously aged as we possibly can.
Yeah, for sure, for sure.
So thank you so much, Carrie. I'm going to give you a small break while you go backstage. Thank you, people, for checking in. Please get your comments into us. I know I have a ton of things that I could use up this time, but we actually want to hear from you, and we want to hear from the audiologists, the otologists, the otolaryngologists in our audience, because I think the more voices we add, the better the care of our patients will be. So we've heard about two aspects of this topic, and I think the third aspect will be very interesting to all of us. I'm very happy to welcome Dr. Richard Gergel on. He's at the University of Utah in beautiful Salt Lake City, where you can float on the lake because it has such a salt content. Rich, take it away.
Thank you so much, Sujana, and thank you for this opportunity to talk about a topic that I'm very passionate about, and that's hearing loss, cognition, and cochlear implants in older adults. So these are my disclosures, none of which will be directly relevant to what we're talking about today. Well, as you've heard so nicely from our first presenters, we know that there's an association between hearing loss and dementia. I think there have been so many large studies from big data sets that have been published that this is really an established connection now between age-related hearing loss and dementia. And there have been some really landmark trials that we've seen recently, just in the past couple of years, as Justin mentioned, with the ACHIEVE trial and the trial he's conducting with the EARLY trial, which we're very excited to see the results. And what I want to do is really look at the extreme end of hearing loss and those individuals who are candidates for a different type of hearing intervention, namely a cochlear implant. And the cochlear implant studies up until now have been fairly heterogeneous, particularly in their length of follow-up, the testing battery that's used as well. And I'll just highlight here, this is the Lancet Commission on Aging, as we've heard about. There have been different iterations of this from 2017, 2020, and 2024. And in this most recent iteration, published in the Lancet, we see here a life cycle of an individual who may develop dementia. And of all of the risk factors for developing dementia, hearing loss is the number one, or the highest relative percentage for attributable risk and a modifiable risk factor. So as we know, and Sujana pointed this out with the WHO data, this is US Census data looking at demographic information that we know very well, and that is that we have an aging population. We are living in the inflection point right now where the number of 65-year-old and older individuals in our society is really growing. By 2030, that number will hit another inflection point for those who are 85 years old and older. So we have an aging population. And as this pertains to cochlear implants, we saw some really interesting information about penetrance of hearing aids. For cochlear implants, only about 5 to 10% of adult cochlear implant candidates in the United States are receiving this intervention. And there are fewer barriers. Medicare covers cochlear implants, but there are still a number of barriers for individuals who are candidates. The average delay from the time that someone becomes a candidate, according to Medicare criteria, to the time they receive the intervention is about 10 years. And the fastest growing segment of cochlear implant users is older adults, where we know in most societies and around the world, birth rates have remained relatively stagnant or declining, but our population of older adults is growing quite rapidly. So there have been some interesting meta-analyses and systematic reviews about various interventions for hearing loss and how that may affect cognition. This was a very nice study published in JAMA Neurology just within the last year or two, looking at both hearing aids, and when the existing data are pooled, the hazard ratio for developing cognitive decline is much lower for those who are using hearing aids. And then when we look at hearing restoration through cochlear implantation, the amount of cognitive improvement, there are cognitive benefits. And so we're starting to see pooled data, observational data mainly. But one question that we've asked at the University of Utah is, what would be the impact of a cochlear implant on cognition in older adults, both at 1 and 5 years after surgery? So we undertook a study a number of years ago, prospective interventional study at our institution, at our affiliated Veterans Hospital. Any candidate who is 65 and older, a cochlear implant candidate, could qualify for this study. And what we wanted to find out was, what is the cognitive function after cochlear implantation? So we did baseline testing of cognition with the mini mental status exam. We wanted to look at the psychosocial component as well. So we measured the geriatric depression scale. But one of the novel features of this study is that we did an extensive battery of cognitive testing that was both verbally based and visually based. And each of those tests is an analog of the other. We wanted to know, when someone gets a cochlear implant, if their cognition improves, is it because they are just simply hearing better, or is there actual benefit to their brain function? So this was a timeline of our study. Baseline, we checked 1 year postoperatively, and now most recently 5 years postoperatively. We initially started with 50 patients who we enrolled. 48 had a data set, baseline data set. We were able to follow 37 up to 1 year, and now 16 up to 5 years. So relatively small study, but we had some interesting findings. At our 1 year study, and this was my triological thesis, this diagram and figures, this shows you for each of the cognitive tests, each one of these was a statistically significant improvement in cognition. So we have tests of various cognitive function. And what you'll see here is the pre-op on the left and the post-op on the right. And each of these tests improved in a statistically significant fashion after 1 year. The blue and the red bars represent individuals who had impaired cognition to begin with, less than 25, and those who had normal cognition. So it was all comers. The group that improved the most was actually that group that started in the worst area with worst cognition. So we wanted to continue to follow these individuals for 5 years. This data is now in press in Otology Neurotology, was just accepted last week. And so what we can see is, in this group, their hearing improves, as we expect, from AZ biotesting of approximately 15% up to 60%. PTAs that went from 86 decibels down to 28 decibels. So as we expect, the hearing improves. But I'll show you some of the cognitive data. So the mini mental status exam over 5 years after cochlear implantation remained stable. And of course, we'd like to see testing improve, but actually stability in this group with an average age of 83, this is a victory to keep their cognition the same over 5 years. This slide summarizes our main findings of the study, which was the verbally based testing. Those did continue to show improvement after 5 years. The visually based testing stayed the same or declined, but declined according to age-related norms. So the clinical significance is, we've seen improved outcomes on verbal testing, executive function, different cognitive domains, stable testing for simple attention, learning and memory, and executive function. We saw a decline in simple attention and learning and memory and sustained attention, but those declines were consistent with normal aging. So this data supports the beneficial cognitive effects of auditory rehabilitation, particularly with a cochlear implant, and further large-scale controlled trials are in the works. So in conclusion, we found that cochlear implants, this is an important intervention for hearing as well as likely cognition in older adults. And the next step is, how do we improve access, make surgery safer? We're currently doing a trial, we call it the COCO study, which is Cognitive Outcomes After Cochlear Implantation in Older Adults. Every clinical trial needs a cute name, and I credit my colleague, Dr. Neil Patel, who's the principal investigator. But we are looking at cognitive function after surgery under general anesthesia versus local or MAC anesthesia for older adults to try to make the surgery safer and more accessible. So with that, I'll thank you.
Thank you so much, Rich. What a great talk. I remember 20 years ago talking to Brad Pickett, who was in New Mexico, and talking about, how we were, daring to operate on what we now call the older elderly and do cochlear implants in people over 75 or 80, and, fighting with their internist because it's a safe operation and so on and so forth, and experiencing individually that the quality of life improvement, aka cognitive improvement, was so much in these individuals. So I think we're going to have some interesting questions about ages and where incorporating cochlear implantation under less and less general anesthesia, but maybe more sedation, maybe more local anesthesia, like Emma Stapleton talked to us from the UK last year at the AOS meeting, will be. So thank you so much. Lots of food for thought. Again, maybe as we all are getting older, we're thinking more and more about how we get older better. And I think this subject is really very helpful for us. Ashley McCaig is an audiologist in Woodbridge, New Jersey, who has tuned in. Thank you so much for watching and being interested. Ashley, I think, between audiologists and otolaryngologists, we're the front line to help our patients and their families understand what's going on. So I will bring back now all of our panelists, and I want to thank all three of you for such great talks and such engaging information that's been given. And I know Brad has sent me a couple of questions to ask. So I'm going to put this out here, and I'll just randomly call on you because I really, really want to be a school marm as I get older. So Katie Kennedy is saying that the cost of hearing aids and even over-the-counter hearing aids remains a huge barrier to access. So how do you counsel patients and their families about affordable options, especially since they're like computers, right? The second you buy it and you leave the shop, it's outdated, or it feels like it's outdated. So Justin, let's start with you.
Sure. Well, the good news, there's a wide spectrum of devices today. And so, I usually start mentioning the gold standard prescription hearing aids, but they're expensive. You can go down to over the counter. But as you mentioned, Sujana, even those are quite pricey, over $1,000. The device I'm wearing right now, the AirPods Pro, the second and third generation, and by the way, I don't have any conflict of interest with Apple, is a great way to pilot what a hearing aid is like. If you have an iPhone, for $300, you can buy one of these and you can demo what a hearing aid is like. With a click of a button, these turn into an FDA regulated over-the-counter hearing aid. And then there's also a Pocket Talker. So lots of devices today.
So I had a funny conversation with a patient who was considering AirPods, right? I said, well, you have a mild to moderate hearing loss. If you want an AirPod as a starter. And she said, I don't want people to know I have a hearing loss. If I'm wearing AirPods, I would have to tell them, no, I'm actually listening to you and using this as my hearing aid. She's like, I'll spend the money and get a hearing aid that nobody can see and I don't have to tell anybody about. So it's a really interesting set of conversations to have with people in the office as they're contemplating. So my parents wrote in and said, battery replacements are really difficult with small fingers. And frankly, we're talking about this with button battery ingestion in children, right? Because a lot of times grandparents are the caregivers for their young grandchildren. And so batteries are not only difficult to use and the controls are difficult, but those batteries, if they fall down and are not taken up, can be ingested by small children. So are there any new devices? And I will tell you, Deborah Burke, who's an audiologist, says the majority of hearing aids now have rechargeable situations, which is great. But I will tell you that if you are the kind of person who uses a hearing aid for 12, 14, 18 hours, you're going to run out of that recharge battery because patients have complained to me. So, Carrie, have at it.
Yeah, I can speak to the over-the-counter kind of space. Those are the devices that we use primarily in our studies around Baltimore, where we work with community health workers to get people up and running with over-the-counter devices. And we try very hard to select devices that we would consider as older adult-friendly options. And so we specifically look for and use rechargeable devices. So, just like Deborah pointed out, there's a lot of options out there. And, we're generally thinking about people with mild to moderate loss who may not be wearing it all day, but sometimes a little bit more situational. So rechargeable batteries are definitely what we would consider a very older adult friendly feature. I think other older adult friendly features to be thinking about in terms of the over-the-counter space is really looking at what the button configuration is in terms of like how large and prominent the buttons are. For many people, it's hard to navigate, between those different buttons on the device itself. So that's one aspect. Also, if there's verbal prompts, that is very helpful. Many of the devices, they try to make them, to be used across different countries and across many languages. But if they have the feature that, when you push the button to change the volume, it says volume up, rather than like beeps and boops that you need to like count and figure out like what was that you just did to your device. So verbal prompts, rechargeable batteries, and, thinking about the layout of it, whether or not you have to have a smartphone in order to program it, whether you have to have a smartphone to use it on an ongoing basis, are all things to consider if you are looking to navigate the over-the-counter market.
Thank you. I think you raised the issue of the smartphone, right? Everybody assumes everyone has a smartphone, and frankly, a lot of people don't. And sometimes that pairing and unpairing can be very unfriendly to people. So it's something that I know our audiologists spend a lot of time talking to our patients about. I don't know if like the Genius bar at the Apple store has geniuses who know how to pair. I have a real problem with that. Have geniuses who know how to pair these things, but I think that has not solved the problem that you're talking about. The people who can use their smartphone love it. They love changing the programs on their smartphone. They love having, a restaurant setting, a concert hall setting, an intimate, tete-a-tete setting, which is very nice. We have a question from Amit Walia, who says, do you use cognition as part of counseling when you discuss cochlear implantation or hearing aids as a potential to explain to them why they may make that choice? And so this is a very nice question for you, Rich.
Oh, thank you so much. And it's interesting. I try to present a very realistic picture to patients. It's interesting. Oftentimes I don't need to bring it up. They bring it up to me, or they're asking questions about hearing loss and cognition. I think this is really an issue that kind of made it into mainstream media. There have been a number of articles about this in the popular public press. So oftentimes patients are asking me about it. And when they do, I try to represent what we know from the literature and provide evidence-based guidelines. It was exciting to see the ACHIEVE trial, the first prospective randomized controlled trial that showed benefits in individuals, particularly who are at higher risk for developing dementia. So we do share that. We share what we know about cochlear implants. That the nice thing with cochlear implants, or really any hearing intervention, there's intrinsic value in the intervention itself for just the hearing. But I do share with my patients, we also feel like there's emerging evidence that it could also help with brain health, memory, the way your executive function, the way you interact with one another, and all the social benefits as well. So I do share that with patients. I also recognize that when this information first came out, I think the marketing may have gotten ahead of the science a little bit, because there was almost a little bit of fear mongering happening where patients, felt like they needed to buy a hearing aid in order to prevent Alzheimer's disease. And of course, Alzheimer's is a very complex condition. And I don't think any of us in this space have illusions that will completely cure Alzheimer's by treating hearing loss. But there certainly is a subset that's at higher risk for developing cognitive decline because of their hearing loss. So that's a little bit of how I'd counsel a patient.
So, there's a follow-up for you, which I think you already addressed somewhat. This is from the follow-up question to Rich, which is a patient comes in with hearing loss and says, am I going to get dementia? Right. And I think I was saying prior to the webinar starting, I think 2 or 3 people asked me this question today in the office. So it's quite common.
It's a great question. And
how do you tell them? What do you say?
I say, and I'd really try to emphasize healthy aging in general, that hearing loss is one aspect and a very important aspect, perhaps the most important single aspect, but it's really about keeping the brain active, avoiding any sort of sensory deprivation, whether it's vision loss and treating that, hearing loss and treating that, but also being socially engaged and just overall keeping the mind and the body active, I think is important. But as a hearing healthcare professional, that's something we're going to have laser focus on to really make sure if you have hearing loss, that's not part of normal aging. I think we need to move past, and I think we are moving past the idea that, well, you know, you're in your 80s, you have hearing loss, that's just part of getting older. That's not true. This is a medical condition that needs to be treated.
You know, I'll talk to my patients about like doing the crossword, taking a different route to work or school or, you know, wherever they're going every day. Like there are different ways to keep that brain firing all the time. Ashley McCaig, who's an audiologist in Woodbury, New Jersey, says she's got many patients who come in discuss hearing aids, and there's been so much publication in the lay media that they're bringing the topic of cognition up. So, Carrie, how do there's rabbit holes, right? Every one of our patients is down. I don't know what is a subreddit, but I know a lot of people are there. So how do we, not fearmonger, not look like we're doing a hypersell, but actually get the patients the hearing health care they deserve? And I think Rich's point of, no, you don't just go gently into that night. You actually say this is a problem that should be treated.
Yeah, I agree with a lot of what Rich has said. To me, I frame it as, you do so many things in your life that you are trying to stay active, that you are trying to stay engaged. You are, you're taking care of your vision, you're monitoring that. This is one more thing in that list of all the things that you're doing that you want to stay as engaged as possible. You want as clear as signals as possible, going to your brain. And right, we're not talking about cochlear implants, yes, in general, right, for hearing aids. We're not talking about a surgery. We're not talking about a medication. We're talking about a low risk intervention that, yes, may have, potential benefits. So that's where I go with that. I will say, though, just to add, where I am a little bit more aggressive are people who come in with already cognitive changes in terms of they have an established diagnosis of mild cognitive impairment or they have a diagnosis of dementia. I am more aggressive in talking with them about, we don't know what the future holds in terms of your memory changes. So we really need to think about how we make sure, again, your brain is getting as clear as signals as possible. So we want to establish those routines. Let's think about getting a device. Let's get going so we can get that as part of your daily life so that that's established. And then whatever changes may come, this is one part of all the things that you're doing to try to stay engaged and as connected as possible.
Thank you. We had a very nice clarification from Deborah Burke, who says, one, lots of people already know about cognitive hearing loss and decline, and they're asking us about it, which is a great way to start that conversation. Two, she said that the rechargeable hearing aids should last you about 15 hours, 16 hours, just like my cell phone lasts me all day long. But my kids who stream all the time, they seem to run out of battery right when they need to call their mother, right? So I think if you're using it for a lot of processing, you're going to run out of battery sooner, and maybe you figure out a way to ameliorate that problem. Maybe you just carry your charger around with you. I had an interesting discussion with one of the senior leadership in a cochlear implant company who happens to have cochlear implant. And this was at the Nashville meeting a million years ago when I got inducted into TRIO. There was a waterfall where everybody was gathering, and his processor kept processing the waterfall, and his batteries kept dying, processing the waterfall. So I think, being cognizant of how you're using your hearing, and even I don't wear hearing devices, but I know that when there's a lot of background noise, I'm processing differently and I'm not paying as much attention or having the bandwidth to hear as well. So there's a great question from Elliot Zakarowicz. How would over-the-counter devices impact cognitive health in speech and noise environments or hearing and noise environments versus hearing aids with DNNs? And I'm going to give that to Justin, and maybe you know what a DNN is.
I didn't have time to pull up ChatGPT to ask that.
I think a deep neural network
Oh.
ability to compress signal.
How ironic. I
sound
was
and
going to
noise.
ask the deep neural network what a deep neural network is. Great question. Speech and noise is more challenging, of course, than speech and quiet, but it represents real world situations. So when people are, using hearing aids, this is often the environment they're in. So this is a great question. I don't really know that much about hearing aids that use these new AI strategies. There's obviously an incredible application for AI to pick out the speaker and silence everything else. I imagine that this will be a nice application of AI. It will improve hearing aids, but I don't know exactly the data of how much better they are currently. But it's an exciting new world.
I think Justin and I are the only people on earth who didn't know what DNN was. So, yes, Rich?
I know what a subreddit is, though.
One of the hallmarks of hearing loss and cognition, this was the work of George Gates, was that it's really hearing and noise where you detect it for older adults. That's one of the real harbingers of impending cognitive decline, because that's a central auditory function to be able to subtract out the hearing and noise. So I think any hearing device that can improve hearing and noise will likely have benefits. And just from an end user standpoint, I think people will like those a lot more. Hearing and noise is still the number one complaint of most hearing aid users. So if an older adult can go to a restaurant or socialize or being in a noisy environment and be more comfortable with their hearing, I think that'll help out quite a bit.
Right. The absolute isolation. I had a young woman today, physician, mother of 3, expecting her 4th child. Hearing aids work great in the office and at home, and she totally degrades when she's around other people. So weddings, luncheons, things like that. And, she's really young, and this is causing social isolation at an age when she really should be the most interactive. So, we're talking about elderly, but we're talking about the aging process, and we're talking about how we multitask everything all at once. And the better we can make it for people, the better. So I think Katie Kennedy had a really good question regarding single-sided deafness. See, I know what SSD means. So what are your thoughts on the impact of hearing aids or cross devices or osseointegrated devices or cochlear implants on cognition in single-sided hearing loss compared to bilateral? And Carrie, I'm going to throw that one over to you.
I can get started, but I'm welcome, Rich in particular, to join in. I think from a public health perspective, which I recognize that this is not, we are often looking at the better hearing ear in terms of a lot of our studies, and we are making a lot of assumptions about kind of what that may mean in terms of day-to-day function. There's obviously limitations to that, but I think that is a little bit of where the state of the science is in terms of we are thinking about kind of the better hearing ear as that's kind of where people are in their day-to-day functioning. There's obviously a lot of nuance that's not captured there. But that is the state of where we are in terms of especially thinking about hearing loss and cognition. We know that there's some connection there that is based on that better hearing ear. But yeah, I think there's a lot to be explored there. So I welcome if Rich or Justin have additional comments.
Just a couple of thoughts on that. It's interesting with single-sided deafness. I'm sure you've experienced this. I can't tell you how many patients come in after a sudden hearing loss and they say, I just feel like I have brain fog. There's just something off cognitively. And in the older adults, I would say more than single-sided deafness, we're really oftentimes talking about asymmetric hearing loss, where the better hearing ear may actually not be doing very well. But I think the real intervention since the 2019 FDA approval for cochlear implants for single-sided deafness, I think the ability to restore hearing in that ear that's lost a significant amount of hearing is really vitally important. One of the challenges we face, of course, is that Medicare does not cover cochlear implants for single-sided deafness or asymmetric hearing loss. But in the past year, we've published a report based on our experience at the VA with people, veterans getting cochlear implants who are older adults for basically single-sided deafness or who would not be traditional Medicare candidates. And they do very well with their cochlear implants and have a lot of benefits. So I do think there will be downstream cognitive benefits as well, particularly for those patients who just feel very disoriented when they have single-sided deafness.
Yeah, I agree with you. I think sometimes, in the United States, the control over access to health, to certain interventions at a certain age rests at CMS. And sometimes it just takes them a while. And I think it's data like all three of you are providing that will help CMS make the right decision that's fiscally prudent, because I think the return on investment is actually super high in terms of all the other things we talked about. I think Carrie's description of the other factors that we should think about is really very important. We have a couple of with many comments, so thank you, and keep them coming. We've gotten some dispensation to stick around for a few more minutes, so please keep your comments coming. Dr. Parham said, if I understand correctly, treating hearing loss can, 1, delay cognitive decline, and 2, slow cognitive decline. But he's asking, is there a point beyond which treating hearing loss may not be effective from a cognitive point of view? And maybe I'll switch over to Justin for this.
Sure. I believe delaying cognitive decline and slowing cognitive decline, essentially same thing. You're kind of changing the slope, the trajectory of the cognitive decline. The key question is there a point beyond which treating hearing loss may not be efficacious? I think you should probably treat hearing loss regardless of your level of cognition. I guess the only limiter would be if you have such severe dementia that you're gonna, throw out or eat your hearing aids, then it becomes futile. But I would say that it helps no matter what, from the beginning to the end.
Do you think, is there some point where they have been untreated for so long, right? So they've let the hearing has gone down and been untreated, and they've gotten a lot of what I think Rich was saying, oh yes, of course you can't hear, you're old. It's the same thing as, of course you have poor balance, you're old. And of course this, and of course that. And meanwhile, we have marathoners who are 90 years old, right? So is there a point at which the counseling is not, we can stop it or we can reverse it, but maybe we can slow it? Carrie?
I don't think we can reverse it. I'll let Carrie take this one.
Yeah. I mean, I think, from my perspective, there's always something to be gained from providing, whether amplification, but I will also say, right, when we have a view of hearing loss management, right, it's sensory management with, hearing aids, cochlear implant, and it's oral rehabilitation, right? And we cannot forget the oral rehabilitation, particularly when we're talking about individuals with dementia, right? There is a lot of value in terms of helping a care partner. Those communication strategies, I know they're not sexy, but they are really fundamental in terms of when people are at their wits' end, are really frustrated with the day-to-day routines that they're trying to get their loved ones through, that if we can make it just a little bit easier at mealtime or a little bit easier, in bathing or dressing or things like that, it can go a long way to remember those communication strategies, and to, and whether it's you put that pocket tucker on for meal times or put that pocket tucker on for doctor's appointments, there's always something that can be done on either end, both with, amplification or with, strategies for care partners, or a little bit of both.
When I did my fellowship at the House Institute, they had those speaker tubes hanging on the wall next to the SMR cabinet. And so you just put one end in the patient's ear, and you wouldn't talk like this, you talk like this, so they could actually face read you. And it was just look, you could either carry around a giant tube or you could wear a hearing aid, but you could possibly hear much more than you are hearing now. And I think that was a really great way to let people know could be done. Barbara Tartaglia says, my mother has dementia, and I'm sorry, Barbara, about that. And she's on medications to help with all sorts of potential side effects. I tell my patients, this is a treatment. Hearing amplification is a treatment that can help reduce cognitive decline without the side effects of all of these medications and all these other treatments. And I think that's a really holistic way to approach how we take care of patients. We got a really nice compliment from, I think from Karush Parham, UConn Otolaryngology, that Dr. Gates, George Gates, would be very proud of all of you three for the advances that you've made in understanding the relationship of hearing loss and cognitive decline. Because it's one thing to just say this is likely, and it's quite another to do the kind of studies you've done and to publish them in a way that is accessible to all of us. So we really do appreciate it. Deborah Burke says, I use the analogy with my patients that wearing hearing aids is not guaranteed to prevent dementia, but it can decrease risk and definitely improve quality of life. And I think that's really important. How many hours per day should people be, let's say they get a hearing aid or hearing aids or a cochlear implant, how many hours per day is the right number for use? Who wants to go for it? Rich?
The more the better, I think. I don't know that there's an absolute number. I don't know that we've seen that in terms of where the benefit is from a statistical standpoint, but I think when someone is in an auditory rich environment, they can potentially be hearing, keeping their brain active, then they should be wearing some form of auditory rehabilitation device, whether it's a hearing aid or cochlear implant. So I'd say the more the better. Staying active, it probably is somewhere around 8 to 10 hours a day would be my guess, basically all day. Certainly if someone's home in a quiet environment, they probably don't benefit as much from wearing those. But I think just putting them on as a standard practice and keeping them on all day is probably where it helps the most. We're in an era as well from a cochlear implant standpoint. We know there's an active clinical trial for totally implantable cochlear implants. We know that's coming as well with a number of companies bringing that to market. One of the potential benefits is you'll be hearing all the time. It's never off, basically. And so I think we'll see when hearing becomes, or hearing rehabilitation just becomes, with a patient 24 hours a day, we may see some real benefits from that.
There's a hearing aid called the Lyric, which goes in and stays in for 3 or 4 months at a time. And the patient has sort of a wand that they wand it on and wand it off. And in those patients, they seem to be using their hearing the way I use my hearing. Like first thing in the morning, they're hearing, and they keep it on all day, and then they kind of wand it off at night, which, I can't do. But I think you're right. The more the merrier, the longer the better. Amit Walia has a really good question as well. How do we measure cognition in our patients, given that we're not doing clinical trials and we don't have all day to be asking them questions? Because cognitive tests can be time consuming. Are there tests, like a blood test? Is there some sort of biomarker that we can think about for these patients? Carrie.
So I will give some thoughts. I welcome Justin and Rich, who may have different thoughts, because I will say, I spend a lot of time with geriatricians who specialize in memory disorders, as well as neuropsychologists who have strong feelings about who and when cognitive screening should be happening. So just to recognize, it's a controversial topic. Because, when you screen somebody for cognition and you find something, you really need to have a lot in place about what you may be conveying to that patient and what next steps you should be. There's, from my perspective, it may not be necessary, or you have to be very, very thoughtful about why it is you are going to be assessing or screening cognition and what you're going to be doing with that and what you're going to be, describing and sharing with a patient.
And Justin?
This is a very broad and complex topic. There's a lot of people think that otolaryngologists should get more involved in testing for cognition, and I don't know if I necessarily agree with that. I mean, I guess you could do a screen if you want. I think really our role is to mention this as a topic, begin the conversation, and refer to someone who really does this for a living. That's my opinion anyway. Maybe others disagree.
we do these tinnitus handicap inventory, we do ETDQ7, we do little test batteries in our office. So is there sort of a simple, maybe not drawing a clock, and certainly by the time my daughter, who is 20, gets to that age, she doesn't even know what a clock looks like. She knows that it's numbers, in a row, right? So, sorry, God. So is there something relatively simple that they can do for in the waiting room or between their audiogram and us that kind of give us a hint about what's going on? Rich?
There are some screening tests like the high MoCA, for example, the hearing impairment MoCA. It's been validated in populations that have hearing loss. So that would be one. And there's a cutoff score. If they're below a cutoff or above it, then it would suggest some mild cognitive impairment or cognitive impairment. And I think the key principle in medicine is if you're going to order a diagnostic test, then you know what to do with the results. And so that's probably where many hearing healthcare professionals feel a little bit uncomfortable because we're not formally trained in cognition. And I can tell you, having worked very closely with a cognitive neurologist, even in their own field, there aren't really standardized screening assessments or even making the diagnosis of Alzheimer's. One of the questions was, are there blood tests, serum biomarkers? We are just now starting to see that there's not a kind of completely validated way to assess for even that basic question, does someone have Alzheimer's disease? But some emerging biomarkers, phosphorylated tau is one. There are others that are coming online, but it is complex, just like Justin said.
So Elliot Zakharowicz has a great comment. Wear your hearing aids in any situation where you're wearing your pants, which I think that's kind of a cute way to say it. Mickey Price says that she's been having this dialogue about hearing loss and cognition with younger and younger patients. And I think as we learn about synaptic ribbons, as we learn about hidden hearing loss, as we learn about hearing and noise, degradation, I think we are seeing this more and more. And I think people are, a little bit more aware of health and a little bit more proactive in their 20s, 30s to get to a really healthy 80s and 90s. My parents are asking, does wearing hearing aids help your voice? Like, what do you think about the other side of communication, not the receptive side, but the productive side? Carrie, you've looked at a lot of aging studies.
Not this particular question, but I think just from what we hear from our patients, I think there's a lot of ways in which, like well-balanced, adequately tuned, when you are aware of your environment, that includes aware, of your own kind of sounds and where it's falling within the larger environmental sounds. So, I think there's certainly some of those benefits. I can't point to the study that says that, but I think from our clinical practice, there's just so many small day-to-day things that people notice when they've got amplification and it's working for them.
Yeah, it probably helps the spouse's voice stop shouting. Probably that voice is better all in all. Bill Slattery, who's our AOS immediate past president, texted me and said, audiologists are becoming cognition specialists, and that's really good. It's a really interesting way to use that big audiology brain and really get out to the people to realize how we can help them. Lots and lots of thank yous, and we really do appreciate it from Anna Kim, from Deborah Burke, from Karush again. Thank you so much. I think what we'll do, because we're coming towards the end, is we're going to hear a comment from the coolest cat around, and that's Dr. Dennis Poe. And, because he is super cool. And he's right. Regarding the embarrassment from wearing hearing aids, I remind people that cool people are walking around everywhere with big Bluetooth devices hanging out of their ears. And in fact, they're back to those giant headphones that used to be with, in the 70s and 80s. So ear devices have become cool, and aging well has become cool. So thank you, Dennis, for that comment. Anything you guys want to say before we wrap up? Rich?
No, I just mentioned again, thank you for hosting this topic. I think this idea of hearing healthcare is just so vitally important. Obviously, we're biased and we see the benefits, but it's remarkable to see how life-changing hearing loss can be for an individual. And then on the other end of that, restoring hearing, people can be so happy, and it just benefits so many different parts of life. The hearing obviously is so important, but the cognitive function, the social aspects, fall benefits, healthcare utilization, all of these benefits. So I think as hearing healthcare professionals, it's really our mission to get this message out and share it and learn more and keep advancing the field. But really making sure hearing healthcare is part of the discussion of a holistic approach for the management of older adults.
Amen.
Yes, agree. Never too early, never too late.
Beautiful. Thank you so much to our wonderful panelists, Dr. Justin Golub of Columbia University, Dr. Rich Gergel of University of Utah, Dr. Carrie Neiman of Johns Hopkins University. Excellent session. Thank you to all three of you for wonderful presentations and wonderful discussion. Thank you to our audience for watching and participating and chiming in. And let's continue the wonderful work. I'm going to let you guys go. So thank you so much. And I'm going to have Brad Kessler come back up. So thank you to you guys and welcome back, Brad. Good job backstage.
Thanks so much, Sujana. It was a pleasure to be backstage. Two quick observations. Number one, I love the audiologist engagement. We had lots of audiologists on the show. They were active and engaged and gave their perspective. I think that's really important for us as ear, nose, and throat surgeons to gain that perspective. The second observation is really about the order of the panelists. We started with Justin, who had talked about early hearing loss, mild hearing loss, some patients with no hearing loss and cognitive impairment. And then we moved to Carrie, who talked about it from the dementia side, from the cognitive impairment side and hearing aids. And then Richard brought us home with cochlear implantations, kind of the end stage, severe to profound sensory neural hearing loss and their impact on cognitive impairment. So I think the order was great. Fantastic panel. One more reminder that abstracts for AOS and ANS at COSM next spring are due tonight, 12 a.m., Eastern time. That's, 12 a.m. West Coast time. That's 3 a.m. East Coast time. Get those abstracts in and come to the meeting. We love seeing everyone, and there's nothing like being together and having our otologic community. So thanks, everyone. Thank you to Digimentors and Neil Perek for outstanding production and direction. And Sujana, I'll turn it back to you.
Thank you, Brad. And thank you so much to Nancy Young. She's the president of the AOS, and she does pediatric cochlear implantation. And she was the one with this brainchild for how important this subject of aging well and hearing as best as we can while we age was so important. Ashley McCaig says, you know what? Saying what all the time is much more noticeable than wearing a hearing aid. And she is correct. So thank you so much for watching. On behalf of Dr. Young and on behalf of the AOS Council, we really appreciate everyone's participation and everyone's input. Have a great evening. Safe, healthy aging and hearing to all of us.